Hello and welcome to everyone who is here on this Friday evening. Welcome to another California Thoracic Society Friday evening educational webinar. Tonight's presentation is titled Autoimmune Pulmonary Alveolar Proteinosis, Apap, Pathogenesis, Presentation, Diagnosis, Course, and Therapy. Tonight's webinar is supported by the PAP Foundation, whose website can be found with more information at papfoundation.org. Our esteemed speaker this evening is Dr. Bruce Trapnell. Dr. Trapnell is an internationally known clinician-scientist. Dr. Trapnell's work focuses on rare lung diseases, alveolar macrophage biology, GM-CSF in lung health and disease, and human gene therapy. The Trapnell Lab investigates the pathobiology of pulmonary alveolar proteinosis, PAP, focusing on the role of GM-CSF in regulating alveolar macrophage differentiation and function. They established the pathogenic basis of autoimmune PAP, developed a blood test that now serves as the gold standard for diagnosis autoimmune PAP, and conducted clinical trials evaluating inhaled GM-CSF as a pharmacotherapy of autoimmune PAP. Trapnell is an endowed professor of medicine and pediatrics at the University of Cincinnati School of Medicine and director of the Translational Pulmonary Science Center laboratory at Cincinnati Children's Hospital Medical Center. He originally trained in pulmonary medicine at the Warren Grant Magnuson Clinical Center at the National Institutes of Health and has served as the scientific director of the PAP Foundation since it was founded in 2006. Before I hand it over to Dr. Trapnell, I'd like to remind everyone there will be an opportunity for a live Q&A following the conclusion of Dr. Trapnell's presentation. If you'd like to ask Dr. Trapnell a question, simply type it into the Q&A input box and he will answer all the questions at the end of the presentation. Without further ado, welcome, Dr. Trapnell.
Well, thank you for that very nice introduction, and thanks to the California Thoracic Society for providing an opportunity to update about PAP, and for the PAP Foundation in supporting this. Let me proceed right ahead if I can get the system to work. Right. So just by way of disclosure, I'm a consultant for a variety of pharmaceutical companies. I have research grant support from federal sources, NIH and NCATS, institutional support, as well as commercial support. The PAP Foundation receives educational support and unrestricted educational grants from various sources as listed. And I will talk about unlabeled, unapproved drug use in terms of GM-CSF as a therapy of autoimmune PAP. The objectives are to essentially to understand that PAP is not a single disease, but it's rather a syndrome that can occur in multiple diseases, to describe the pathogenesis of autoimmune PAP, which is a single disease, describe the natural history of autoimmune PAP, as well as methods for its diagnosis, and current efforts to evaluate the safety and efficacy of inhaled GM-CSF therapy of PAP. So as I mentioned, PAP is not a single disease, but rather a syndrome that is characterized by the progressive accumulation of surfactant in pulmonary alveoli that results in restrictive lung impairment, hypoxemic respiratory insufficiency, and in severe cases, respiratory failure and death. It's a diffuse disease or syndrome actually, but this is the radiologic appearance of autoimmune PAP here. You can see that it involves all lobes. The CT scan has a characteristic, but not diagnostic appearance, and that is one of ground glass opacification superimposed on interseptal thickening, interlobular thickening, that has an appearance which is often described as crazy paving. There's some other examples of that in a bit, which I'll show, but you can see the very geographic nature of it. Histopathologically, alveoli are generally well preserved. The alveolar wall, as you can see on the bottom left, is quite well preserved, but the alveoli is the alveoli are filled with a granular material. That material stains with surfactant antibodies, surfactant protein antibodies, as you see in the middle panel there on the bottom. And ultrastructurally, the material is consistent with that of typical surfactant. Alveolar macrophages are enlarged and foamy because they can take up the surfactant initially, and they process part of it, are unable to export the cholesterol, and therefore become foamy with intracytoplasmic lipid droplets, which are primarily cholesterol. And one of the lesser known aspects of this, of autoimmune PAP, is the increase in infection risk that comes with the pathogenesis, as shown by this MRI scan of the first patient I ever saw. I saw him years after this scan was taken, but he presented with seizures and his lung disease was missed because he was seizing. So that's another aspect of the problem. Now, mechanistically, PAP causing diseases can be classified in multiple groups. The first group is that associated with disruption of GM-CSF signaling. The second group is involves a reduction in alveolar macrophage functions and/or numbers. The third group is involved with the disruption of surfactant production and/or structure and function. And finally, there's an unclassified, lesser well understood group of PAP causing diseases. In the first group, there are three members currently: autoimmune PAP, which is caused by anti-GM-CSF antibodies. There's a group that is involved with the GM-CSF receptor dysfunction from mutations in either the alpha or the beta chain of the GM-CSF receptor, and a recently described disease involving STAT5B signaling deficiency. STAT5B is just downstream of the GM-CSF receptor and mediates some of the effects on surfactant clearance that are mediated by stimulating with GM-CSF. In the second group, hematologic disorders, in particular myelodysplasia, are common causes of secondary PAP. Myelodysplasia is the most common cause of secondary PAP, but other forms involved inhalation of toxic dusts like silica or aluminum, titanium, and a number of others. There are several immune deficiency syndromes that can result in development of PAP. There are genetic disorders, GATA2 deficiency, and various other genetic mutations that can be associated with PAP. And chronic infection itself, for example, with HIV and others, can lead to immunodeficiency and can involve PAP. In the category of disruption of surfactant production, these involve, they're generally genetic diseases that involve mutations in the surfactant proteins that lead to a deficiency state, either in the amount or the function. Disorder involving mutations in ABCA3, which is involved with producing the lipid component of surfactant, and developmental lung abnormalities caused by mutations, for example, in NKX2.1. And in the unclassified category, recently described PAP causing disease, methionine transfer RNA synthetase mutations, and systemic juvenile idiopathic arthritis, which can lead to recurrent macrophage activation syndrome, and that in turn to PAP. Of all these different diseases that are associated with PAP, autoimmune PAP is the most common and accounts for about 90% of all cases. The rest of this talk will be about autoimmune PAP primarily. So in terms of epidemiology, autoimmune PAP occurs in men, women, and children, anywhere from 3 to 90 years old. It can present, although typically it presents in a previously healthy adult individual age, 30s and 40s. It does affect individuals in all geographic regions, regardless of race, ethnicity, or socioeconomic status. The prevalence of autoimmune PAP is proportional to population density, and this has been demonstrated in Japan and the US. In Japan, a national registry study, identified a prevalence value of 6.2 per million in the general population. And in the US, in a study that involved health claims insurance data for 15 million covered individuals, measured the prevalence at 6.8 per million. And both these are probably underestimates. And a recent estimate has been as high as 26 using a Poisson distribution method based on evaluating incidence data. So it's roughly the prevalence is about 6 to 26 per million. Risk factors include smoking. And there's recently been a study identifying HLA allele associations. In terms of the clinical presentation and course, the clinical presentation is usually one of progressive dyspnea of insidious onset, but can also include cough, fatigue, and sputum production, which do increase during the course of the disease. Fever and hemoptysis are not typically part of the presentation and really only occur when there's a secondary infection that's also present. In terms of the clinical course, most patients are initially misdiagnosed with pneumonia until the failure of antibiotics to improve the patient's condition prompts diagnostic reconsideration, referral, GM-CSF autoantibody testing, and clarity about the diagnosis. Sometimes the diagnosis can be delayed for years because of this difficulty. Secondary infections are important and can account for about, historically, for about 18% of the mortality from PAP. Pulmonary fibrosis can occur. It's not clear exactly who's going to get it and when, but it looks like about maybe approximately 20% of patients might get it at some time in their clinical course, typically towards the end or towards later stages. Hypoxemic respiratory failure is really the cardinal pathophysiological feature, and the patterns can be one of a stable plodding disease, a more rapid decline in people with more serious severity, and sometimes in about 5 to 7% of patients, there may be spontaneous improvement. Further with the presentation and or the signs, the sputum cytology in PAP is shown here. When it does occur, it's typically a white frothy material. It's not usually the green or blood-streaked material like that unless there's an infection present. You can see with the various stains, with the PAS stains or Diffquick or PAP stain, you can see that there are a number of large foamy macrophages and a lot of debris. Surfactant is part of that, cellular fragments. Basically, it's dirty looking. And the BAL fluid itself, I didn't show that here, but the BAL fluid is a white, milky or yellowish, opalescent, cloudy material. I'll show an example of that in a minute. I mentioned that the alveolar macrophages are large and foamy. They stain positively with oil red O, and that's because of the cholesterol ester accumulation that happens. And in the bottom three panels, on the left, on the bottom, is an alveolar macrophage from an 18-year-old with autoimmune PAP. And you can see the large foamy cell with the single membrane delimited intracytoplasmic lipid droplets that contain mostly cholesterol and cholesterol ester. In the middle panel is a alveolar macrophage from a primate that was previously healthy but was injected with antibodies purified from an autoimmune PAP patient. You can see that it developed the foamy appearing macrophages. In contrast, a primate that had been injected with saline alone did not develop that foamy appearing alveolar macrophage morphology. In terms of pathogenesis, the first clue about the pathogenesis came in 2004, the first real clue, when GM-CSF deficient mice were discovered to develop PAP spontaneously. PAP was first described in the 50s, around the time surfactant was discovered. And over the years, there was some hint that there was a problem in terms of inhibitory protein, but it wasn't until the mouse was discovered that GM-CSF was clued into the pathogenesis. Shortly after, or around that time, GM-CSF was identified as being required for alveolar macrophage differentiation in the lungs in both mice and humans. Subsequently, GM-CSF autoantibodies were found to be present in people that then had idiopathic PAP. This was in 1999. Konakata's group found that. And oddly, the levels of antibody did not correlate with disease severity, but the antibodies blocked GM-CSF signaling in patients very efficiently. And again, oddly, the antibodies were present in healthy people, but at low levels. So it was not completely clear about the role of antibodies in the pathogenesis at first. That led to the hypothesis that GM-CSF autoantibodies did cause the disease, but only when present at high levels. And a Cox postulates type of approach was used in establishing this hypothesis in the way that we understand it today. So we were able to show that high levels were present, high levels of the GM-CSF autoantibodies were present in patients with idiopathic PAP, but not others. They were isolated in pure form from patients with idiopathic PAP. Administration of these isolated antibodies to healthy primates reproduced the cardinal features of PAP. And when the antibodies were isolated from patients directly or from passively immunized primates, they had the same potency in terms of GM-CSF signaling inhibition. So this is the data that strongly supports the concept that the antibodies actually cause the disease. This led to a reconsideration of idiopathic PAP as an autoimmune disease directed with a humoral antibody response directed specifically at GM-CSF. This slide shows some data about evaluating GM-CSF signaling in blood using a CD11b stimulation index test. That is to say, you treat blood with GM-CSF, and that increases the level of CD11b on blood leukocytes. And you can see that as the antibody level in the blood of these individuals increases, the ability to stimulate a CD11b index response is decreased. When we evaluated autoimmune PAP patients, we found that they had essentially no signaling, and a critical threshold of 5 micrograms per mil in serum using the assay that we developed was identified as the threshold for an increased risk of having PAP based on this antibody test. We saw the same pattern when we injected antibodies into primates, the same critical threshold and the same essential pattern. So this slide summarizes what we now understand about the pathogenesis of autoimmune PAP. On the left is a healthy alveolus with GM-CSF being secreted by type 2 and other cells, acting on normal alveolar macrophages, causing them to mature, differentiate, and to be able to clear surfactant adequately to maintain a thin surfactant layer that is sufficiently thin to allow normal oxygen delivery and normal blood oxygen levels. In contrast, in PAP, in autoimmune PAP, GM-CSF autoantibodies block GM-CSF signaling essentially completely and lead to the formation of foamy alveolar macrophages that are filled with cholesterol and cholesterol ester droplets. They are then unable to clear any additional surfactant, which builds up, becomes a thickened layer, and fills some alveoli completely. It does result in an increased cholesterol to phospholipid ratio, which alters the biophysical properties of the surfactant. And there's also some biomarkers that are increased. MCSF goes up because it's de-repressed in the absence of GM-CSF, as is MCP1. And the current thinking is those might be kind of backup mechanisms to recruit functional cells, but they are neither one of those cytokines are able to replace GM-CSF, and so the disease develops. And all of this leads to chronic hypoxemia due to reduced oxygen delivery, and that can lead to polycythemia in severe cases. So now I'm going to turn to a few slides about diagnosis. And the first question is a lung biopsy needed and or useful for diagnosis of autoimmune PAP? So here's a lung histology from a patient with autoimmune PAP caused by the antibodies. In the second panel here is hereditary PAP caused by mutations in the alpha chain of the GM-CSF receptor. And the third panel is hereditary PAP caused by beta chain gene mutations. And all three of those things would require a different disease-specific kind of treatment. And yet you can't distinguish them based on the lung biopsy. And in fact, further complicating the problem, because of the patchy nature of the disease, lung biopsies don't even always identify that PAP is present. In our national registry study, almost a third of the patients did not get a diagnosis of PAP, let alone autoimmune PAP, even after having one or more biopsies. So a lung biopsy has a poor sensitivity for detecting PAP. It cannot identify any PAP-causing diseases, and it is associated with some significant mortality. So in my book, a lung biopsy is not needed for diagnosing autoimmune PAP. In contrast, the blood test for the GM-CSF autoantibody, as you can see from this slide, is quite specific for autoimmune PAP. It's very highly elevated in patients with autoimmune PAP and in all other conditions, including other kinds of PAP-causing diseases, other lung diseases, or healthy individuals. The value of the antibody is quite low. And so this test is essentially 100% sensitive and specific. In addition, though, there are GM-CSF signaling tests that can be done. And both of these tests are actually commercially available at Children's Hospital in Cincinnati and also National Jewish Hospital. And there should be information on the PAP Foundation website, and we'll just make sure that that's updated about how to go about getting that testing done. But anyway, on the right is the GM-CSF signaling test. And this test basically is done by incubating aliquots of blood with GM-CSF, and after a few minutes, then evaluating for the presence of phosphorylation of STAT5, which is an immediate downstream signaling molecule downstream from the receptor. You can see that there's a quite robust response normally, and that autoimmune PAP patients essentially don't respond. So this is a quite good test that we use as a confirmatory test. And because you can develop PAP based on a high level of a low affinity antibody or a low level of a high affinity antibody, because these are polyclonal antibodies, IgG antibodies, these two tests form a nice complementary pair of tests for diagnosis of autoimmune PAP. So this is the algorithm that we currently use for diagnosis of patients with PAP syndrome. You have a patient that's suspected or known to have PAP based on compatible history and radiographic findings. You can confirm this by a BAL or a gross cytologic evaluation or biopsy, but that's not recommended. And in either of those two cases, serum GM-CSF autoantibody test would be the next thing to do. And when that's positive, because of the high sensitivity and specificity, a diagnosis of autoimmune PAP can be made. When it's negative, then you have to look for other causes. And so we typically go through the gamut for looking for secondary PAP. And when there's an explanation and no other, then we can diagnose secondary PAP. When that is negative, we do a serum GM-CSF test. And when that's positive, that's elevated in GM-CSF receptor mutation type PAP, either alpha or beta. And that's useful in diagnosing hereditary PAP. When that's not positive, but there are surfactant-related gene mutations that are identified, that's helpful in identifying surfactant production disorders. And when all of that's negative, we resort to looking at the histology and other types of tests to determine what type of PAP is present. We have adapted the serum GM-CSF autoantibody test to a dry blood spot card test, and that's just in under review for publication. But basically, this allows patients at home or in the clinic, perhaps, as is done for other diseases, to just take a blood spot test and drop it in the mail. It can then be evaluated, and the results can be returned in a relatively simple way, which helps for diagnosis at distance and also makes it a bit cheaper. Turning now to therapy, the current standard of therapy is whole lung lavage. In this procedure, the patient is under general anesthesia. Each lung is intubated individually and separated using a Carlin tube. That's possible. In little kids, that's not possible, but you have to use separate tubes. But any one lung is mechanically ventilated while the other is filled with saline and drained repeatedly. Generally, about 30 liters per lung is good in most adults, in my opinion, but sometimes up to 50 liters per lung. You can see that the material that is washed out forms a sediment upon standing. On the bottom left, you can see a bag that has a sediment that's forming. And if you let it sit in the fridge overnight, you can see a pretty dense solid layer of the material as it settles out compared to the saline that was used to put in. And on the right, you can see X-rays showing at first before the lavage, you can see the diffuse process throughout all lobes. You can barely see the heart. And then after the treatment, close to a week later, you can see the heart borders and the diaphragm borders a bit better. But it's not completely efficient, but it does help a lot. The last few slides are about GM-CSF and the use of inhaled GM-CSF, or in this case, molgramostim in this particular study, as a therapy. So the Impala study, which was published a couple years ago, excuse me, was a global randomized double-blinded placebo-controlled trial of inhaled GM-CSF therapy in autoimmune PAP patients that was conducted in 138 patients at 34 centers in 18 countries. The inclusion criteria, this was an adult-only study. They had to have diagnosis of autoimmune PAP based on a chest CT, lung biopsy, AADO2 of greater than 25 millimeters, and a PaO2 of less than 75 millimeters, or a drop in the PaO2 on exercise testing of 4%. They had to have unremitting or progressive disease. They all had an antibody to GM-CSF, and whole lung lavage was permitted because that was the standard of care, and oxygen was permitted if that was necessary because that's also the standard of care. Exclusion criteria included the usual pregnant, breastfeeding, other causes, other diseases, but also some PAP-specific stuff. They couldn't have had other types of PAP treatment that were at that time sometimes used. Also GM-CSF within 3 months, no recent whole lung lavage, plasmapheresis, or rituximab. And again, whole lung lavage and supplemental oxygen were permitted for ethical reasons. The trial had 3 groups. There was a continuous daily administration group that got 300 micrograms every day. There was an intermittent group that got daily molgramostim, inhaled GM-CSF, every other week with placebo on the off weeks just to maintain blind. And the third group was placebo. And 45 to 47 patients in each group. They were randomized. They went to their blinded treatment period, which was 24 weeks, and that was followed by an open label treatment during which everybody got the intermittent treatment. And the efficacy was measured as change from baseline to 24 weeks. Safety was measured throughout with monitoring of adverse events. The primary endpoint was the difference in oxygen concentration between alveoli and blood, the AADO2. Secondary endpoints included, again, change from baseline in St. George's Respiratory Questionnaire total score, the time to first whole lung lavage, remember that's the current standard of care, and the number of whole lung lavage procedures, the distance covered during a 6-minute walk test, the diffusion capacity of the lungs for carbon monoxide, and the ground glass opacification score on a chest CT scan. Safety endpoints were enumeration of adverse events and serious adverse events throughout the study. There was an intention to treat analysis used. All patients receiving any intervention were included in the analysis, and missing data were imputed using standard statistical methods. There was a full analysis set that included all the data, including invalid data for 4 of the 138 patients that had received oxygen while blood gases were being measured. While the blood was collected, they were on oxygen, so it wasn't really possible to calculate the ADO2 properly. This didn't affect any other variables. There was also a revised full analysis set that excluded those 4 patients, 1 in each treatment group and 2 in the placebo group. So it was relatively well balanced. Efficacy data, this is the primary endpoint data here. And you can see over the 24-week period, the 2 groups separate. And at the end, in the revised full analysis set data, there was a statistical difference between the 2 groups. The DLCO followed a similar pattern of a divergence between the groups over the period and was statistically significant at the end. The SGRQ total score followed a similar pattern with separation between the groups over the period, and that was statistically significantly different at the 24-week period. The same pattern was seen for the change in 6-minute walk test distance. However, the variability of the data was such that the difference was not significant between the groups. The ground glass opacification score, which was measured visually by inspection, was improved during treatment after 24 weeks. And there's an example on the left and the summary data on the right. This was also statistically significant. And very importantly, the change in requirement for whole lung lavage, measured as the number of whole lung lavage procedures per patient year, so that the data could be normalized and expressed together, is shown for all patients before the trial and during the blinded intervention period for the placebo versus the continuous molgramostim group. You can see there's a drop in the molgramostim group compared to the placebo, but the placebo was similar to the prior or before the trial data. And then during the open label period, there was a further decrease in the use of whole lung lavage in this particular group. This is not part of the Impala study, but just a separate study to show the effects of GM-CSF on the appearance of the BAL fluid. And you can see before treatment on the left, you can see a quite dirty appearing cytology on the BAL fluid. And then after GM-CSF 6 weeks or 12 weeks, you can see a gradual improvement in the appearance of the cells present. And at the end of 12 weeks, really looked quite good. So back to the Impala trial, with respect to efficacy during the open label period, I'm just going to briefly show a few slides here that show first for the AADO2, here we have on the left here is the blinded period, and then on the right in gray is the open label period data. And you can see that during the period where this particular group got continuous molgramostim compared to placebo, there was a separation, but that went away during the open label period. There was continued improvement, but it wasn't very much of a difference between those groups. Similarly, for the DLCO, there was an initial separation, and then during the open label period, when patients were getting either intermittent or, well, actually everybody was getting intermittent, the groups kind of came together. There was still some improvement. Similarly, the SGRQ total score, initially widely separated during the blinded period, and then when everybody was getting intermittent GM-CSF, there was continued improvement, not quite so rapid, and the groups kind of came together. And finally, the pattern seen for the 6-minute walk test distance, again, there was a separation initially, although it was a variable and not significantly different, and the trend continued during the open label period. In terms of safety data, the rate of all adverse events in the continuous group versus the placebo group was not different. Those events that were identified as possibly or probably related adverse events were also not different. AEs leading to discontinuation of the intervention were not different. And serious adverse events overall were not different between the continuous group and the placebo group. So just to conclude, for this part of it, the Impala 1 study, and before, PAP is a syndrome with multiple etiologies. Autoimmune PAP accounts for 90% of patients and is mediated by GM-CSF autoantibodies. Blood tests, but not lung biopsies, are highly sensitive and specific for a diagnosis of autoimmune PAP. And studies that have been reported, and some that I haven't talked about, identify GM-CSF as a critical pulmonary hormone that's required constitutively. Inhaled GM-CSF therapy of autoimmune PAP, compared to placebo, the daily administration of inhaled GM-CSF in patients with autoimmune PAP resulted in greater improvement in outcomes reflecting the physiologic, radiologic, biochemical, and clinical manifestations of PAP. There was also a reduction in the need for whole lung lavage rescue therapy. There was no difference in the occurrence of serious adverse events, and administration every day was more effective than administration daily every other week, the so-called intermittent administration. I didn't show that data, but because it's not very interesting, but that was a difference. Continuous therapy is better than every other week therapy. And there are still outstanding questions that are related to defining the exact dose that's needed to start with, the time to maximum treatment benefit, and the durability of the response. Impala-2 is a trial that is currently ongoing. This is a long-term daily inhaled GM-CSF therapy trial where there are two groups, molgramostim, 300 micrograms every day, versus placebo. And the double-blind treatment period is a 48-week period. The primary efficacy analysis will occur at week 24. The double-blind period is followed by an open-label period where everybody's going to get daily GM-CSF for 48 weeks. And the key features of the study design for the Impala-2 trial, this is a global phase 3 study in 160 patients. All patients can receive GM-CSF during the open-label period. The long-term study of daily inhaled GM-CSF therapy is the focus of this study, and it's designed based on results from the Impala study. The primary endpoint is DLCO. It's expected to provide data that is sufficient for FDA approval. Secondary endpoints are, again, St. George's Respiratory Questionnaire total score, the activity score for the St. George's, and change in exercise capacity, now measured in a more rigorous way than the 6-minute walk test, and using peak metabolic equivalence as the measure. So I'd like to thank the PAP patient community for their participation in the Impala-1 study, in the Impala-2 study, as well as a number of other studies that we've done over the years. And I'd like to thank the Impala-1 investigators who I've listed here. There's a lot of them, so I'm not going to go through the names. And I'd like to thank all the folks at Savara who helped design and execute these studies. And there's a whole host of other people that have helped our group along the way to sort out the pathogenesis and diagnosis of autoimmune PAP, and a number of sponsors of this work. And I'd like to thank all of them and all of you for your attention. So thank you. Okay.
Thank you so much, Dr. Trapnell, for a fantastic presentation. As you might imagine, there are quite a few questions that have already been queued up, so I'm going to jump right in. And of course, you're welcome to see the questions that I'm going to be reading to you through that Q&A panel. So to begin with, the first question, is there a limit on how often a patient can undergo lavage procedure? Is it possible and safe to undergo 2 lavage procedures within a week of each other, one for left and one for right lung?
So yes, so the second question is clearly, yes, it is possible to do that. And often patients at our institutions and a number of other institutions get their first lavage and wait only a few days before their second lavage. Some centers do both lungs on the same day at the same time. Well, not everybody does that for conservative reasons. And the first part of that question, or the first question in that series, is there a limit on how often a patient can undergo lavage? There is no talked about limit for the number of lavages that a patient can have. That's not to say that it doesn't matter, but there's no knowledge about a limit that people understand together as this is the limit. The most that I'm aware of is it's about 150 or 154 lavages that a single person had in their lifetime. And they went through all of that. I'll stop there.
Great, thank you. Next question. I had read that there was no familial link with Apap. Does the discovery of the HLA association suggest that there might be a familial link?
Well, that's a very astute interpretation of the data. And I think the discovery of the HLA association does suggest that there might be, but there has been no identified familial link. in autoimmune PAP.
Thank you. Next question. As a patient with PAP for 15 years now stable status, what are the risks post-general anesthesia beyond normal anesthesia risk? Is it likely to cause the stable PAP to worsen? Extended post-op time on ventilators necessary?
I think I'm not aware of any data that says the anesthesia itself makes PAP worsen. I'm aware of no data to support that idea. Extended post-op time on ventilators necessary. Well, typically ventilator use after lavage is not prolonged. If there's a complication, that might be necessary, but typically extended post-op time on a ventilator is not required. I'm not sure if that's enough of an answer. If that's not getting exactly at what you're asking about, maybe you can try again, and I'd be happy to try again.
Okay, great. Next question. If a patient is receiving IVIG, will the GM-CSF blood test be accurate to determine if the patient has PAP or APAP?
That's an interesting question. Never heard that one yet. Well, I think this is referring to the idea that IVIG has as its most abundant cytokine autoantibody, antibody to GM-CSF. So in almost every prep of IVIG that was evaluated in a study that we looked at a decade or so ago, almost all the preps had detectable antibody to GM-CSF. However, it is very low in abundance. So I think it's probably very unlikely that routine use of IVIG would significantly influence the test result. But I love that question, and I think that we will attempt to evaluate that. So we'll at some point we'll have a more specific information about that. I doubt that it will interfere, but it might.
Thank you. Next question. Is clubbing present in PAP patients?
So that's a little bit difficult to answer as is, because PAP occurs as a really heterogeneous group of diseases, some of which are associated with clubbing and some of which are not. Autoimmune PAP is not associated with clubbing. Some of the more fibrotic type of PAP diseases, like surfactant gene mutations that are primarily associated with fibrosis and variable degrees of surfactant accumulation as a kind of a secondary feature, but it buys it into the group of PAP, those patients can have clubbing associated with the primary problem. It's not universal, but that's where it can happen. So clubbing not present in autoimmune PAP, but is present in some other types.
Thank you. Next question. How many tests do you get a month to diagnose via blood test APAP? Has there been uptick after education of doctors?
Well, we do the tests every week. There's probably, I'm going to guess, maybe 3 to 5 tests a week, every week. It varies some. I mean, that's the average. Has there been an uptick? I'd like to think that's the case. I don't have enough information to really give a good answer to that, so I'm not going to make one up.
Thank you. Next question. Will this be studied in children?
By this, I assume you mean inhaled GM-CSF, and if that's the case, it will be. Right now, we're going after the primary target, the main group, adults. But there has been significant discussion of when and how to study this formally in children. And it is already being used in children with autoimmune PAP, but only as an off-label treatment.
Thank you. It looks like this next question was the same. I'm going to move on to the next. If inhaled GM-CSF is not possible due to Sorgen's disease causing dry upper respiratory, are there other options? What are current findings in the Rituximab efficacy?
So I think what this is asking is if a person has autoimmune PAP, but also has Sjogren's disease that's associated with dry upper respiratory, et cetera, is it possible to use, if it's not possible to use inhaled GM-CSF, can you use something else like Rituximab? Well, let me address the Rituximab question separately first. There have been a few small studies, case reports, and one small study of Rituximab therapy of autoimmune PAP. And although the case reports were, they described a quite good response in an N of 1 in each of the case reports, altogether, the data for Rituximab is not strong. That's not to say that it doesn't work. It's just that the data supporting it and demonstrating that it works well is not strong. So I think that Rituximab is not something that I would ever recommend as a primary approach to treating any kind of PAP, especially, autoimmune PAP, and certainly not now in the COVID era. Further detail or further study is needed to understand whether Rituximab has a place in therapy of autoimmune PAP. There's been no identified treatment approach to using Rituximab that has been helpful. So the question is open. It's just not clear whether it's going to turn out to be the greatest drug ever developed for or used for PAP, or doesn't work at all. It's just not possible to say. And the issue of Sjogren's is probably, I think it's difficult to answer in this way. I'd be happy to have a further detailed conversation individually, but I don't have anything to say generally about it, I think, at this point.
Thank you. Next question. Is it recommended that the patient takes medicine that help liquefy the surfactants prior to the lavage? Is the use of antibiotics recommended after a lavage? If yes, for how long should antibiotics be administered for?
All right, so that's definitely a series of related but not the same question. So the use of antibiotics in PAP by itself, forget lavage, is something that's not universally accepted. There's clearly a rationale for using certain kinds of antibiotics. For example, Bactrim, which is helpful against nocardia infection, which is oddly more common in PAP. And some individuals use that as a prophylactic therapy. Not everybody does. It makes some sense. Bactrim has its own side effects. So it's the kind of thing that you really should individualize, I think. But that's just a personal opinion. It would be useful to have evidence-based data to support whether people should have prophylactic antibiotics on board, and because this is an immunodeficiency. Liquefying surfactants prior to lavage is an interesting idea. It has not been demonstrated to be useful. There is no method to make that work right now. That's an opportunity waiting to be discovered for somebody to actually figure out a way to make that work, but it hasn't been yet. So there's nothing that people have done to liquefy the surfactant other than warm the saline to body temperature, which is theoretically helpful. It does make the surfactant a little bit less hard, let's say. And if you're going to use antibiotics during in the peri-lavage period, I don't know that that's often done, but it's not unreasonable to do it. And if there's any question about a pulmonary infection during the time that the lavage is done, having antibiotics on board is definitely a good idea. And the consequences or the negative consequences would be little. So, and how long, that's something that there's really not a good data for. If I had to pick a number out of the air based on experience, generally not specifically. I would say that a few days would be probably okay.
Great. Thank you for answering all those questions there. Next question. For the first patient you had met with PAP, what type of infection did he have in his brain? To what extent are these patients immune compromised, and do we understand why?
Yeah. So this patient had Staphylococcus epidermidis, I believe. It's been quite some years ago. And that's, just a bug that's out there. It's not, it's not particularly bad bug. It's just out there. In some reports about PAP, there's a description of the increased frequency of opportunistic infections. But the reality is that there's a wide range of microbial pathogens that animal models of PAP show increased susceptibility to. And there's a number of different types of pathogens to which patients with PAP have infections with. So it's not just opportunistic. It's a generalized, but in my opinion, relatively mild immunodeficiency. I don't want to go on about it, but so I'd say the summary point is that there is a mild immunodeficiency. It is responsible for 18% of the mortality from PAP historically. These days, there's a lot less of that because people are tuned in and pay attention, and antibiotics are present, and so things can be dealt with. I would say, on the subject of infection, nocardia is unexpectedly common in PAP patients, and sometimes presents with brain abscess, which is a terrible thing. Anyway, that is one of the reasons, I think, underlying some physicians' use of prophylactic antibiotics to try and prevent that from happening. I may better stop there.
Thank you. Next question. Could you share again the information on the at-home GM-CSF test and how to obtain it?
Right. So I think what I'll do is we'll make sure that the information is complete and clear on the PAP Foundation's website. But I can just say that we have not, what the right term is, we have not rolled out this test generally because we're just about to finish the reporting of it initially, and we're currently doing a validation study. So maybe it's not quite ready for prime time, just because we need to dot the I's and cross the T's. But we will put an update on the Foundation's website that will describe the status and how to go about getting some testing. And if anybody has a question about testing, you can put a question in through the PAP Foundation's website, and that question will get answered.
Thank you. Next question. As a patient, what is the life expectancy of Apap?
Well, in one study that was reported in 2002 that evaluated 410 patients with PAP of all types, at that time it wasn't understood about autoimmune PAP, but still the prevalence was probably 90% or so of the total cases. The use of whole lung lavage improved life expectancy by, I think it was 5 or 10%. I forget exactly. So the point of that is that there is a reduction in the life expectancy if not treated. It's not huge, but it's there. And the risk is about 70% due to PAP effects in the lung, and the rest is from infection. Hopefully that was useful.
Thank you. Next question. Can you explain the pathophysiology of the crazy paving interlobular thickening pattern on CT?
Well, I can tell you how I think about it. There's a couple of different things. First of all, when you accumulate something, fluid or solids, in the alveoli, they fill up, and that is one way to get a ground glass opacification and on the CT scan, and that looks like a kind of a fluffy cottony or fluffy cotton appearing substance. And on top of that, the filled alveoli are the unit of the lung, which is known as the secondary lobule. And in each secondary lobule comes an airway and an artery and a vein, and there are lymphatics that drain the extra fluid from tissues, right, throughout the body. But anyway, the secondary lobule, that's the structure. And what happens is that a secondary lobulus can become filled up with surfactant, but the one right next to it might not be filled. Almost like if you have a double laundry sink and you have water flowing into it both sides, but one gets plugged up and so it fills up, and then right next door, the other one's just empty. And it's sort of like that. That's how I think about the crazy paving. And there's more to that story that relates to the lymphatic drainage. But this is an area that is not particularly well understood. Interesting, though.
Thank you. Next question. When would Molgridex come on the market, and how much would it cost?
Don't know about the cost. The goal of having it become approved by the FDA is that insurance companies would then pay for it. So the cost would be like other medicines. It would be covered by the insurance. When it's going to come on the market? Well, the current study is going well. This is the Impala 2 study. This is the study that we believe will be enough for approval once we're completed. And it's going to take another few years to complete everything. So I don't want to put a number on it that I don't actually know, because I don't know the number, but it's going to be less than 10 years, more than 2 years, let's say. Probably, 3, 4, 5 years, I guess. Hopefully I'm not misspeaking about that, but I think it's going to take a little while to finish it up and get everything submitted and have the data evaluated, et cetera.
Thank you. Next question. Can a newly diagnosed patient be administered the medication without having a lung lavage?
Yes. And if it is approved by their insurance company, it can be paid for.
Fantastic.
That would be an off-label, what we call an off-label use. It's not approved by the FDA, but there's an overwhelming amount of data supporting the safety, and also a pretty decent amount of data supporting the efficacy or the treatment effect of inhaled GM-CSF in autoimmune PAP. So I think that, yes, you don't have to have a lavage first. I would say, though, a relevant piece of information, if you get a lavage, you might be better in days. You might feel better in days. If you get whole lavage, or if you get inhaled GM-CSF, it's going to take a little bit of time to have a treatment effect. It might take a month or 2 or 3, but the expectation is that the treatment effect will be greater in the end. That's my expectation personally, based on the information that's available. So one is quicker, but less efficient, and the other is a little bit slower, but much more efficient.
Thank you again. Next question. Is there any protection in PAP for bacterial infection? Because I've treated with lavage sort of 5 patients. All of the patients have had crazy paving pattern with GGO and big consolidations and high values of RCP, but normal procalcitonin, and we didn't treat with antibiotics.
Well, that's a pretty interesting idea. In fact, surfactant, which has a lipid component, it has the 4 proteins, 2 of the proteins, A and D, the surfactant proteins are A, B, C, and D. A and D have very distinct and reasonably well-described antimicrobial effects. A is a very sticky protein, so it's possible that the surfactant is somewhat helpful in preventing infection. I don't have specific knowledge about this in PAP, but when you think about what's known about surfactant proteins and their role in host defense, and their great excess in PAP, one can imagine that they might be helpful in preventing infection. Personally, I wouldn't rely on that. It's kind of an interesting, weird thing that seems to happen maybe, but I'd go for the antibiotics when necessary. But that's a very individualized thing, and I am not making any kind of recommendation, just thinking out loud about it.
Great. And just wanted to note the follow-up question was a comment that followed this, just noting all of the 5 patients finished the bronchial lavage and are well.
Great. Well, that's interesting.
Thank you. All right, next question. Is there data for taking cholesterol medication? Does it help?
There is data. The data is very interesting and very sparse. There's only a few patients that have been studied in detail that have taken a cholesterol modifying medication, for example, rosuvastatin. One in particular, a lady that had quite a lot of whole lavage and it wasn't working all that well for her. She went on rosuvastatin because she had also familial hypercholesterolemia, and she was well, and it took a little while, but a year or so, and she was very well after that. But that's an N of 1. There was a couple other cases that we've done. So there's a great interest in thinking about this, but it's not clear how, what the treatment effect actually is. So does it help? It's not clear. Looks like it might. We need more data before making any kind of a recommendation.
Great, thank you. Dr. Trapnell, it looks like there's a small follow-up question that I'm going to jump to one ahead. It says, when you mention the cholesterol and inability to rid of it, what exactly do you mean? Does this have to do with diet?
Right. So cholesterol is the key to life and the reason 1/3 of us die with cardiovascular disease. I'm being a little bit dramatic about that. I'm not trying to be funny, but basically it's a double-edged sword. Cholesterol is very important to a number of cellular processes and signaling. And so it's just a critical molecule. However, like many things, too much of it is not good. And all cells have a protective mechanism where when they are exposed to too much cholesterol, and it builds up inside the cell, they esterify it. That means they chemically modify it and then stuff it inside little droplets. And that's what makes the macrophages big and foamy, and also helps to make them not function very well to do what they're supposed to do. So when I talk about cells not being able to get rid of the cholesterol, normally when surfactant is made and used, it's then cleared away very quickly from the alveolus, or the little air sac. And the way it's cleared is part of it is degraded, that is the phospholipid part, and the other part, one of the other parts, the cholesterol, is exported by the macrophage, and it goes somehow back to the liver. How it gets there is not really quite well known. And so when the macrophage doesn't have GM-CSF on board, it can't export the cholesterol out of the cell. And so that's why it builds up the macrophages. And because it builds up there, the cells become foamy. They then don't do their job, and then surfactant builds up in the alveolus, and then they can't breathe. So that's what I mean. It's not really so much about the diet. It's about the cell getting rid of it, exporting it out of the cell. And that's where GM-CSF is required. GM-CSF has a number of effects on macrophages and many other cells. One of them is about managing cholesterol, and that's what's particularly relevant here. Just by way of analogy, in cardiovascular disease, atherosclerosis, there's also formation of foam cells with cholesterol in the blood vessels. And so in that location, there's basically the plaques clog up the flow, and that causes real trouble. So there's some interesting biological similarities. But cholesterol is generally taken from tissues, including macrophages, back to the liver through a process called reverse transport. And that's what's disrupted in the absence of GM-CSF signaling. That's what I meant by it.
All right, thank you. Well, here we are, our last question for the evening. With 22 whole lung lavages, 44 individual procedures over a 15-year period, and several years of trying inhalation of GM-CSF periodically, we're not seeing a huge improvement. We've yet to expand outside of the Kaiser Stanford systems for treatment. Any recommendations of where to reach out for future PAP treatments or info that may allow for further treatment options?
Right. So in having this discussion, I would ask how the GM-CSF has been administered and how much and how long. As part of that conversation, I would add that one of the things, there are a number of things we don't know about inhaled GM-CSF. One of them is, what is the right starting dose? We really don't know what the right starting dose is. In several trials that have been done, a value of 250 micrograms per day in a trial in 2010 resulted in 2/3 of patients having a clinically significant response. In a more recent study, 300 micrograms of a different formulation resulted in sort of half to a little bit more than half of patients having a clinically significant response. The issue here is that the current round of studies that have been done, or the past studies that have been done, have used a value of 250 to up to 500 and sometimes even higher. But basically, it's not clear what amount is going to be needed in any patient. And currently, there's no method to identify what that dose should be. It's kind of a trial and error. So if someone has not had a response to GM-CSF, I would scrutinize the amount and how it was delivered to determine whether they actually got and what I would consider to be an adequate amount of treatment. And that's a little bit of a judgment call to say. Where to go outside of that, I'm not sure. I mean, there's certain centers that are looking at this biologic problem and clinical problem. I think what we can do is try to make sure there's a good summary on the PAP Foundation's website. I'll have to look and see what's actually written, but we can try to make sure that that's as thorough as we can make it. I think
real quick, Dr. Trapnell, I'd like to be sensitive of your time to just check in real quick with you. We typically, obviously, schedule these from 5 to 6 p.m. It's a little bit past 6 and a few more questions have come in. Do you have a few more minutes?
I do. I don't want to disrupt your plan, but I'm happy to talk for a few more minutes if that's useful.
Absolutely. Completely up to you. We really encourage and support this Q&A session. So let's keep going. And if you have any final questions, please type them in now, as we are going to try to wrap up after this last group of questions. All right, next question. It's from someone who's asked a question before. I'm not sure if it's a follow-up. Okay, no, it looks like a new question. Have you ever seen a 72-year-old man, former smoker, started shortness of breath, history of lost 40 pounds of weight in the last year, and started crazy paving pattern in HRCT, and started to secrete white, foamy liquid orally? We quickly sent this liquid to our pathologist, and she did PAS and concluded by multidisciplinary discussion it could be PAP. What do you think we must search? Because it seems to be a secondary PAP. Do you agree?
Well, the easiest thing to do is to make sure of what it's not. And that is autoimmune PAP. 90% of cases are that. 72 years is absolutely in that category that it could be that. I'm not suggesting or saying that it is, but that's the easiest thing to do, just from a statistical standpoint. And if it's not autoimmune PAP, then I think there has to be a very careful history taken to identify secondary PAP causes. There are some, at age 72, and if there is no significant fibrosis, it's unlikely to be a congenital type of PAP, like a surfactant disorder or a lung development disorder or something like that. I would look for the occupational exposure history The 40-pound weight loss is significant. That doesn't really, I don't fit that into anything just yet. So I think I would have to ponder this one and look at all the data that I could manage, but I would be looking more for secondary PAP and looking to the occupational exposure history to see if there was some reason there. But the first thing would be to exclude autoimmune PAP. That's just a blood test and then you're done.
Thank you. Next question. Does APAP affect premature newborns, and does giving exogenous surfactant affect them negatively, especially with repeated doses?
There are no cases that I'm aware of premature babies developing PAP. In fact, it's kind of the opposite. Premature babies are too young and their lung epithelium is too immature to make adequate amounts of surfactant. And therefore, without surfactant, the little air sacs collapse and they get, this pediatric lung disease of newborns. And giving surfactant relieves the problem by replacing the missing surfactant, allowing the air bags to stay open during the breath. So no, autoimmune PAP is not something that we've ever seen in a premature baby. I would not expect it. It doesn't make physiologic sense for that to happen, based on what I just tried to explain.
Thank you. Next question. What are the side effects of the medication?
Of the medication, I assume that you're talking about GM-CSF. And so the side effects that are known are sometimes people can be allergic to some aspect of the medication. Pretty rare. I've seen maybe a couple of examples that I'm convinced about. Sometimes about 3% or maybe 3 to 5% of the population has very reactive airways. They would react to basically anything you inhale. And so, for example, even if you were inhaling albuterol, which is intended to cause airway relaxation, some people even react negatively to that for the physical material that's present. So that's a side effect of inhaling something, including GM-CSF. But there are no other clear-cut side effects other than immunity related, as I mentioned before, and irritant related. No other serious side effects from GM-CSF, which is the great thing about it. I would say that if you did not have autoimmune PAP, but rather you had a different kind of PAP or no PAP, taking extra GM-CSF can cause, not necessarily through the lung route, but if you were taking it subcutaneously, which some people still do, you could influence the bone marrow to make an excess of white blood cells, and that could give you anemia. There's one case that I'm aware of where that happened. But when used properly, that's not really an issue.
Thank you for the expanded answer. Next question. Where does the recombinant GM-CSF come from? And is it possible to increase its therapeutic effectiveness and manufacture cost?
Good question. So there's two types of GM-CSF formulations that are out there now. One of them is commercially available, one of them is in development. One of them is made in yeast cells, and those cells are very similar to our own cells, not exactly the same, but they have a general similar structure called eukaryotic cells. They have a nucleus, et cetera. And then the other form of GM-CSF is made in bacteria. And the two forms of GM-CSF are different in that the GM-CSF made in bacteria doesn't have any sugar molecules on it. It's so-called glycosylation. Most proteins have some kind of glycosylation, sugar molecules on it, in a specific pattern. And so the yeast-made GM-CSF has glycosylation, and the bacteria-produced GM-CSF does not. The absolute biologic activity is a little higher for the non-glycosylated E. coli version. However, practically speaking, I think it doesn't matter. I don't think there's any real practical pharmacologic difference. They haven't been compared. So we don't really have, well, we've done some studies in the lab, but there's been no proper comparison. So we can't really say that one is more effective than the other. And I don't know about the cost of manufacture. I'm sorry, I can't answer that.
All right, here we are. The final question for the evening. Let's see if I can get this word right. Next question is, any interest in herbal remedy trials, such as mullein leaf or others?
I'm interested in it, but I don't have any actual knowledge of it. So I don't have anything I can add. Sorry.
No problem at all. Thanks for taking a shot. Well, you have made it to the end of one of the longest lists of questions we've ever received for our Friday evening webinar. I cleared out about 20 thank yous that showed up in the Q&A in the chat section. So I just want to make sure you know how appreciative our audience was. We had almost over 75 people hang out until the very last minute here with us. At one point, we had over 100 folks listening in to your presentation. So just really wanted to give a big thank you to the PAP Foundation and you, Dr. Trapnell, for such a fantastic presentation.
Well, thank you very much. I'm very happy to be able to do this.
Well, let's see. You want to slip one last answer in?
Okay.
All right, here we go. This is truly the last question we're going to receive tonight. Hello, I am a 23-year-old patient from Australia. Have you ever seen any of your patients develop circulatory issues in their hands and feet after diagnosis with the appearance of chilblains?
I have not. I am interested to learn something more. So if you email me, maybe we can have some discussion. I don't know anything more about it, though.
Perfect. Well, we appreciate you taking an attempt, especially from an attendee coming all the way over from Australia to listen in potentially. Well, once again, thank you so much for your time. Thank you to everyone who just spent the last hour and 20 minutes with us on a Friday night. Please get home to your families, enjoy your weekends, be safe, and we hope to see you on our next upcoming Friday evening educational webinar. 2 weeks from now, we'll be having our next event. You can visit the calthoracic.org website to find more information. Again, if you'd like to find more information or any of the answers Dr. Trapnell gave tonight, you can visit the papfoundation.org website. And thank you all again. Have a great weekend. Be safe.
Thank you. Good night.